Hi, my name is Jorge Castillo, and I'm the clinical director of the Waldenstrom's program at the Dana-Farber Cancer Institute here in Boston. I've been taking care of patients with Waldenstrom's over the last 8 years. And today I'll be happy to talk to you a little bit about Bing-Neel syndrome. I know most of you already know about this, but I will be happy to kind of give a few minutes introduction of what this is all about, what treatment options we have available for this type of condition, and obviously, how do we look into this into the future. So for this, I'm going to share my screen, and we're going to just talk about first how Waldenstrom's manifests itself in many different ways. So this is one of the ways that we have to look into all this. Some patients with Waldenstrom's will have no manifestations of the disease at the moment of diagnosis. It will be asymptomatic or minimally symptomatic, while other patients over time, they might actually become symptomatic or be symptomatic at diagnosis. As most of you do know, anemia is a very common presentation, hyperviscosity and neuropathy as well, and there are so many other different clinical presentations for patients with Waldenstrom's. But one of the rare presentations is this condition called Bing-Neel syndrome, which is essentially a condition in which the malignant cells, the Waldenstrom cells, do gain access to the brain and the spine, and they can cause symptoms because of the presence and inflammation and other processes that these malignant cells induce by the presence of these cells in these organs. Now, as you can understand, the manifestations of Bing-Neel syndrome are also very varied, and depending on where in the brain is located, where in the spine is located. So if it's the areas are affected more in the lower side of the brain, where the cranial nerves are, then patients can have cranial nerve symptoms. Specifically, some facial paralysis, maybe some other areas of the face are being affected, or the smell, or the hearing, or some things like that. Sometimes when the brain has specific areas as well affected, either by masses or other problems, then we could potentially have some limbs being affected, and some other areas of the body being affected. Some patients can present with seizures and headaches and altered mental status. Patients get a bit of some confusion in which patients sometimes they don't know who they are, what they are doing, or where they are, or what some things are useful for. Had a patient that didn't know what a doorknob was all about, for example. But there are other patients that can have a bit more subtle symptoms of this, some headaches that do not go away, some specific numbness in specific areas of the face or the body that do not go away, typically more regionalized instead of being bilateral, or we do that we see in neuropathy, for example. And then when the spine is affected, also other symptoms can occur, specifically pain in the lower back, or specific pain radiating to specific limb or not related to these diseases. So how do we investigate these conditions? So number one, we need to suspect it. About 1% of all the patients that we see in our clinic might have this condition of Bing-Neel syndrome, but we need to suspect it so we can actually diagnose it appropriately. So once we have a suspicion, clinical suspicion that this could happen, we usually order 2 different tests. The first test is an MRI of the brain and the spine. MRIs tend to be better than CAT scans, specifically because we're looking for, sometimes we do see masses, which the CAT scan can show, but in most cases, it's not masses. In most cases, it's just this very superficial inflammation of the lining of the brain. And the CAT scans are not as good as the MRIs for that specific, we call it meningeal enhancement, this abnormal enhancement. So MRIs need to be done with gadolinium. Gadolinium is what will provide that additional enhancement that is necessary to visualize these abnormal areas of the brain and the spine. And I will show you some pictures in a minute. So that's the first step. Now, over 90% of patients with Bing-Neel syndrome will have abnormalities in the MRI, but about 10% might not have any abnormalities in the MRI, and that makes it a little more challenging. That's when we need to have a second step. Regardless if the MRI is positive or not, we always have to take some spinal fluid test, spinal fluid from the patients. We do that through a spinal tap, and we obtain amount of fluid, and we send this fluid to be evaluated for the presence of malignant cells that, the profile of those cells should match the profile of the malignant cells in the marrow. Sometimes we do send for MYD88 mutations. We send for IgH gene rearrangements. In a way, we're trying to do is matching those cells with the cells in the marrow. And to make the proper diagnosis, those cells would need to match, right? The cells that are in the marrow should be the same cells that are in the brain or in the spinal fluid. So in that way, we make a formal diagnosis. Now, we do have a very small group of people with very likely Bing-Neel syndrome that MRIs are negative, in whom MRIs are negative, and also spinal fluids are negative. But we believe the patient might have Bing-Neel syndrome regardless because of the symptoms or other findings. Those patients obviously do not have confirmed Bing-Neel syndrome, but they can have probable or possible Bing-Neel syndrome. And we need to understand that that is also a possibility. So that's the way we actually make a proper diagnosis. In most cases, the patients are symptomatic enough that we need to treat. But in some cases, we don't. We do have a handful of people with Bing-Neel syndrome who had initial symptoms, and that's what prompted the testing. But then the symptoms did resolve, and the patients are essentially asymptomatic. So the sole diagnosis of Bing-Neel syndrome should not mean the patient need to be treated if the symptoms are minor or negligible or none. So if the patient has Bing-Neel syndrome and the symptoms are affecting the patient's activities of the daily living, that's when we proceed to treat. Now, there are multiple treatment options that we have been using over the last several years. What we need to understand is that for Waldenström, we have multiple treatment options, and the same treatment options that we use for Waldenström's can be applied for Bing-Neel syndrome. The issue is not every treatment for Waldenström's crosses into the brain or the spinal tissue. And that's where the problem comes, and that decreases the number of options that we have available. So classically, we have had chemotherapeutic agents crossing into the blood-brain barrier. And for that, we have methotrexate, which is a classic one. Cytarabine is another one that we use, fludarabine. And there's some data with bendamustine, which is kind of plus or minus, but has been used in this specific setting. So those are the options. Rituximab doesn't cross, ofatumumab doesn't cross, cyclophosphamide doesn't cross, bortezomib, carfilzomib, ixazomib, they do not cross into the blood-brain barrier. So as you can see, many treatments that we use for patients with Waldenström's cannot apply in patients with Bing-Neel syndrome just because these medications do not cross into the brain. Now, more recently, we do have data with the newer treatment options, specifically ibrutinib, BTK inhibitors. Ibrutinib, we did a study in which we actually showed that ibrutinib penetrates into the spinal fluid, and that can be seen in many other conditions too. So specifically for patients with Bing-Neel syndrome, that initial finding led us to start using ibrutinib in patients with Waldenström's and with Bing-Neel syndrome. Ibrutinib is highly effective in patients with Waldenström's. We have patients, over 90–95% of patients do respond, and those patients have durable responses. I'm talking about Waldenström's specifically. And so we started using ibrutinib as a treatment for patients with Bing-Neel syndrome. And this experience was published in Blood a couple of years ago. And we actually put 28 patients on this study. I think about half of the patients were from Dana-Farber, and the remainder were from other centers in the United States and Europe. So interestingly enough, what we focused on was in symptomatic improvement, radiologic improvement, that means the MRIs, and cytologic improvement, that means the spinal fluid. At 3 months, we see that the majority of patients had an improvement in the symptoms as well as the MRIs, with some improvement into the spinal fluid burden of disease. When we do get to at the 6 months with something very similar, and at 12 months, even a higher proportion of patients were benefiting from these treatments. When we look at the entire population of 28 patients, about 85% of patients did have either improvement or resolution of the symptoms that initially prompted the diagnosis of Bing-Neel syndrome. This is with ibrutinib single agent without any additional treatments. When we looked at the MRIs, about 85% again had either resolution or improvement of the radiologic symptoms. So these are outstanding outcomes. But when we look at the spinal fluid component of this, only half of the patients had clearance of the spinal fluid, while the other half did not. At the beginning, this could be problematic because when we treat patients with a more aggressive primary brain lymphomas, the goal of the treatment is to clear the spinal fluid. That's how we measure the efficacy of the treatment. But in a condition like Waldenström's, in Bing-Neel syndrome, in which these are not aggressive conditions and they are incurable conditions, I think it is okay that the spinal fluid still has malignant cells in there. When we treat patients with Waldenström's, there's still malignant cells in the bone marrow, and that doesn't mean the medication is not working. So as long as the patient has improvement and resolution of the symptoms, as long as the patients have improvement in resolution of the MRI findings, regardless if there's half of the patients with still evidence of spinal fluid disease, I think that ibrutinib is a medication that actually works in these patients. And when we look at the survival of these patients over time, this is 28 patients. Most of the patients were seen between 1 and 2 years of the treatment, but the large majority of these patients were still alive, so many years over treatment. Now, this was a publication more than 2 years ago. We're working on an updated, larger sample of patients. But in this study, about 2 years, we had about 75% survival rate, which is an outstanding outcome compared to what we have seen previously with other treatments. Now, as you all know, ibrutinib is approved by the FDA for the treatment of patients with Waldenstrom's, and also zanubrutinib was recently approved for patients with Waldenstrom's. This is a study in which one patient with Bing-Neel syndrome in Australia was treated with zanubrutinib. And we can see the MRI just to show you here. There's a bit of inflammation in the cervical area. You can see this discoloration on the before aspect of things, and a bit more in the thoracic part as well, a bit of discoloration on the spinal cord. And after treatment with zanubrutinib, I think it's about 6 months into it, really there's not a complete resolution, but a much more improvement in terms of the inflammation in both locations as well. There was another area of the lower spine as well that I didn't put here, but also there was improvement in there too. The patient has been on zanubrutinib already close to a year and continues doing very well. So I think the BTK inhibitors in general terms do penetrate into the spinal fluid. We don't have a lot of data with acalabrutinib, but I know our colleagues in the brain lymphoma group here are using now also acalabrutinib in that setting. But we don't have any data on Bing-Neel syndrome. But I do believe all the BTK inhibitors do penetrate into the spinal fluid. So in our clinic, BTK inhibitors have become the standard of care for patients with Bing-Neel syndrome. And only if the patients progress or do not tolerate BTK inhibitors, then we move into treating these patients with chemotherapy. There is some data that maybe venetoclax, a new medication that might be coming up for patients with Waldenstrom's, can also penetrate into the spinal fluid. So maybe that's another treatment option for patients in the future. And I think the clinical trials are very rare in patients with Bing-Neel syndrome. We're trying to come up with a clinical trial in patients with Bing-Neel syndrome, but it's difficult because the number of patients is very limited. But we will try at least to have some prospective, idea of how these medications might work in these scenarios. So I think that's the message that I have today. We have better treatments. I think the patients with Bing-Neel syndrome are surviving longer than previously because of these treatments precisely. And I think the future, looks very promising as we treat more patients with Waldenström with conditions, with treatments that penetrate into the spinal fluid. Then we can actually come up with better treatments for patients with Bing-Neel syndrome as well. With that, thank you for your attention.